What do you see
There you
now?
go.
Yeah. Okay. Thanks. Um, okay. So it's through the Global Surgery Research Unit, and it's to look at cholecystectomies and trying to evaluate sort of benchmarks for safety to help guide other people who are trying to incorporate them more in their practice. So, kind of a background. So, laparoscopic cholecystectomies for the non-surgeons are pretty much one of the most common surgical procedures that general surgeons perform, and one of the most common just in general of all surgeries. And they're the gold standard for many like biliary pathologies, usually like infected gallbladders and gallstones. Now, because it is a minimally invasive surgery and it is able to kind of help these patients so quickly and so effectively, the readmissions and complications we're seeing with patients with gallbladder disease is now primarily related to the operation itself. So previously, the perioperative mortality was more from the disease process itself and also intraoperatively from the surgery because it was done in an open fashion. And now we're seeing more burden on the healthcare system because potentially there is a lack of maintaining safety benchmarks of laparoscopic cholecystectomies. And then there isn't a great, I guess, breadth of evidence to talk about the variations in practice for safe laparoscopic surgery for gallbladder disease. So this is just a picture of, for if you've never seen a laparoscopic cholecystectomy, that's kind of how we set up our ports and we go at the gallbladder and take it out. So the study design, it's a prospective international multi-center observational cohort study, and it's delivered by the Global Surge Collaborative. It's a contemporaneous data collection of the quality of cholecystectomies using measures covering both infrastructure, the surgery itself, and the outcomes. So the aims of the study are to define global variations in perioperative standards. And so the way they're doing that, and basically their secondary aims, are to determine rates and quality of intraoperative safety. We'll go through the criteria of how they're, like what benchmarks they're using for that. To assess overall frequency of adverse events and how these adverse events are managed. We're analyzing rates and outcomes of gallbladder cancer that we find incidentally. So this is patients who we don't know they have gallbladder cancer. We find it on this surgery and how often that happens and if those patients do better or worse than the average patient with gallbladder cancer. And then to evaluate variation in services and training and identify sustainable practices. So I'm going to let Cody kind of talk about the actual data collection portion, considering he's done quite a bit of it already.
Cool. Thanks, Hannah. Yeah, I'm Cody. I'm one of the second year med students working on this project. So like Hannah said, this is kind of split into a few different stages of where we're collecting data. And what I've done is just put screenshots on 3 slides that are showing the form we're using to extract this data from Epic. And then we're taking this sheet and inputting it into REDCap, and that is what is happening at every center internationally. So for the preoperative period, you can see on here, we're collecting first like just general demographic information as well as anesthesia status and any relevant comorbidities, any history of cholecystitis or biliary symptoms in the last year. And then we mark down any preoperative imaging that they've had. For the most part, it's ultrasound and CT, but any pertinent imaging we put there. And then the findings on the imaging, if it's gallstones, if they have a thick wall or any fluid, things like that. And then also we put the days from their first symptom onset to when they're admitted to the hospital. And then after that, the time between their diagnosis to the decision to operate and the time between the decision to operate and the time that they had actual surgery. And then the indication for that surgery with some specific grading scores that we use. So I can talk a little bit more about that in a second, but that's generally what it is. And then for the intraoperative data, we're going in and looking at the op notes and also the anesthesia note, and we're taking the mode of anesthesia, who the primary operator was, whether that was an attending or a resident, and then based off of that, kind of going and putting in how many surgeries they've done prior to this procedure. And then the operative approach, obviously, like Hannah said, most of these are laparoscopic, but every once in a while there'll be a robotic case or an open case. And then we'll put if it was converted to open and if there were any complications that made that happen. And then again, there's another intra-op score for how difficult the procedure itself was. And some specific questions here about the type of operation performed, if there was a drain, if there were variants, or if there was a common bile duct exploration or a bile duct injury, and then any other complications related to the surgery, we're all adding that in here. And you can go to the next one. And yeah, for post-operative outcomes, this is the prospective part of the study. So we're looking at 30-day outcomes after the surgery. And again, another scoring system called the Clavian-Dindo system to rate the complications that they may have had post-op. And then unplanned readmissions, unplanned reimaging, basically any deviation from the standard course of recovery after a cholecystectomy. And we're doing that after 30 days, and then again after 1 year. And since this is our first cohort, we haven't reached the year outcomes yet, but we will in August. So we'll fill that out next year. And you can go next, yeah. And so just kind of our current status where we are now with all of this, we're about midway through our data collection of this cohort. Like I said, we'll have the year follow-up in August. Some sticking points and limitations that Hannah and I have observed so far. From her perspective, capturing all the surgeons who are performing these lap choles at the U can sometimes be challenging, especially if there's like a surgical oncologist who, for example, does a lap chole on their long-term patient. It can kind of be hard to know that that happened because most of the lap choles are done by a single like cohort of surgeons generally here at the U. So that can sometimes be challenging to make sure we're including all the lap choles that are happening. And then from my perspective, kind of looking at some of this data in Epic, a lot of the surgeons use templated op notes. So there can sometimes be challenges with pulling specific data points when it's kind of a template. And then, like I mentioned, one of the things we're looking at is the number of surgeries performed by the primary operator, and if that primary operator was an attending or a resident. And so we kind of, with talking to Dr. Nunez, who's one of the attending general surgeons here, came up with a guesstimate for how many surgeries a resident has done, for example, based off of what year they're in residency. And so that is kind of what we've recognized as a limitation that is not super exact or maybe not perfectly accurate. And then finally, something from my own experience that can be difficult is determining how I was talking about the days between symptom onset and diagnosis and decision to operate. That can be pretty nebulous sometimes, just combing through the notes in charts to figure out exactly when somebody presented with symptoms, especially if they're already hospitalized and now are getting a procedure when they were here for something else. So we've kind of recognized those as potential sticking points, but overall, I think it's been going really well. And I'm excited to see where the data goes, and I think it'll be interesting comparing to other centers. So yeah, I don't know if there's anything else you want to add, Hannah, but
no, I think the biggest limitation that I am thinking about when I would like interpret the data from the study is just knowing that so many institutions are using templated operative notes. And while I think that by far the majority of the time we do get a good critical view of safety and things are accurate, and we do edit our templated notes to reflect what actually happened in the operation, I do know that there's a lot of human error in them.